Hello everyone, welcome to our Zoom meeting. Today we will have different topics and Dr. Sabry and his team will be presenting today. So welcome to our Zoom meeting and Sabry, when you are ready, please go ahead. Thank you.
All right. Thank you very much for introduction, Dr. Nadia, and for welcoming us. My name is Dr. Sabry. I'm going to be the moderator for today's meeting. And our team is the Indigo One team. And we have 5 topics for today. Our agenda will be with the first meeting, with the first presentation, about the multiple myeloma in geriatric populations presented by Dr. Amna. If you are ready, Dr. Amna, you can go ahead.
Assalamu alaikum, can you hear me?
Yes, we can. Alaikum assalam wa rahmatullah.
Good morning, everyone. Okay, I'll try to share. Can you see my screen?
Yes, we can.
Okay. Are you able to see the full view or the presenter view?
Come again, please.
Can you see only the slide or any additional things?
No, only the slide, full view of the slide.
Okay, thank you very much.
All right.
Good afternoon or good evening, everyone. My name is Amna Eisawi. I'm a fellow in the Indigo Team 1. I am a general practitioner here in Saudi Arabia and an ECFG certified professional. Today, inshallah, we'll be talking about multiple myeloma in the geriatric population. I have designed this with very limited knowledge on the topic, so hopefully, inshallah, it will be informative. This presentation will uniquely consider points specific to care of geriatric population. So it will not be a classic academic presentation on multiple myeloma only. We'll be focusing more on the geriatric population care. Okay, so the agenda and the learning objectives for this presentation would include understanding the epidemiological status and shift, some brief information about the pathophysiology of multiple myeloma in older patients, very brief. Then after that, we'll move on to see how we can recognize the clinical picture and diagnostic criteria, evaluate frailty and physical performance metrics, and then how to navigate therapies for transplant ineligible patients specifically, and how to implement supportive care and toxicity management. Okay. Now, multiple myeloma is an incurable malignancy of plasma cells. It's predominantly a disease of older adults, with the median age at diagnosis being 68. According to the SEER Cancer Statistic Review, which collects data in the United States, they issued a review that included data from 1975 to 2018. And it concluded that the median age at diagnosis with multiple myeloma was 69. And it also showed that more than one-third, slightly more than one-third of the patients were aged more than 75 years at diagnosis, with about 10% of patients being more than 85% at diagnosis. Okay, The incidence of multiple myeloma was found to be increasing with age, and this combined with the overall aging population worldwide is anticipated to generate nearly an 80% increase in the number of patients with multiple myeloma that are aged more than 65, that are diagnosed each year by 2030. So simply speaking, by 2030, the cases are expected to increase even more. Therefore, healthcare providers treating older adults must be equipped to identify multiple myeloma's unique disease presentation and diagnostic challenges, especially when it comes to the involvement of the elder population. Now, as I said, we will not be discussing the multiple myeloma academic part in details. However, we'll move very briefly through the clinical picture and the laboratories, and then we'll focus more on the aspects of care tailored to the geriatric population. Okay, so regarding the clinical picture, the common presentation includes four things: anemia, bone pain, elevated creatinine and hypercalcemia, and their associated signs and symptoms. Starting off with anemia, it happens to be in about 73% of patients associated with fatigue and the signs of symptoms of anemia. Anemia usually reflects bone marrow infiltration by clonal plasma cells in bone marrow failure. The second most common presentation is bone pain with about 58%, and this results from lytic bone lesions that could be in the ribs, spine, and pelvis. After that, we have elevated creatinine at a percentage of about 48%. And the elevated creatinine basically reflects renal impairment from the light chain deposition. And lastly, hypercalcemia at about 28%, which is a hallmark metabolic complication of plasma cell disease. Okay, moving on to the next slide. Now, even though those were the most common presentation, sometimes geriatric population could present with vague, non-specific symptoms, leading to diagnostic delays, and unfortunately, a presentation with advanced disease, impacting eligibility for therapies, including hematopoietic cell transplantation. Now, while looking at a case of suspected multiple myeloma, there's some criteria that we can use to recognize the disease once suspected. The classical CRAB features, which show us the end organ damage, consisting of the mnemonic CRAB, C for calcium inhibitions, R for renal insufficiency, A for anemia, and B for bone lesions. Those four components usually show us that there is actually end organ damage. However, there is another marker, that's the SLIM marker, or the SLIM criteria, that presents should present with myeloma-defining events before the progression to end organ damage. And those include some very specific hemato-oncologic tests, such as the bone marrow clonal plasma cells percentage being 60% or more, and the involved / the uninvolved serum free light chain ratio being 100 or more, which are specific hemato-oncologic tests. In addition to MRI with more than one focal lesion measuring 5 millimeters or more. Any CRAB or SLIM criterion should be sufficient for diagnosing multiple myeloma. Now, the classic diagnostic workup should start with managing any emergency event. And then after that, doing which is the ABCs, tailoring to the airway, breathing, and circulation, and then doing the basic blood work, including the complete blood count, the renal function test, and the liver function test, and all of the needed investigations. However, of those investigations, most specifically for the multiple myeloma, we should also do the monoclonal protein measurement, which is it's essentially done before to have a baseline and then after to evaluate response to therapy, and it could be done via serum or urine. And then after that, the serum free light chain measurement, again before and after, so that we can have a baseline and see the response to treatment. It allows treatment responses to be assessed earlier than protein electrophoresis alone. And then finally, it's very important that we have a thorough renal assessment, getting a baseline, because there's very high prevalence of renal impairment in multiple myeloma. Now, because isolated serum creatinine is unreliable in older patients because they have reduced muscle mass, or it could be unreliable in older patients because they have reduced muscle mass, there is an equation that's called the Cockcroft's-Gault equation that could frequently be used for estimating renal function and guiding medication doses in older patients. Okay. Now, other than the blood test, bone marrow biopsy and imaging are also important when it comes to with the workup of multiple myeloma. A bone marrow biopsy remains the gold standard to quantify the clonal plasma cells and obtain what's called as cytogenetics, which are very specific hemato-oncologic tests that are needed to kind of specify the type of the proteins and so on, including some panels such as the fish panels. Other than the bone marrow biopsy, advanced imaging is also important because lesions that are causing bone pain can lead to pathologic fractures and spinal cord compression. So things like PET-CT or whole body low CT, low dose CT, is also required to assess the lytic bone lesions. Okay, I am sorry for kind of moving very fast through the initial slides, but the bulk, inshallah, would be regarding the geriatric assessments and specific points related to geriatric patients' care. Okay, now moving into management, we face older patients in general have a very high prevalence of frailty. Okay, and does anyone know what frailty is? I can't see the messages, so if anyone wants to open the mic and answer, it's totally fine.
Maybe it's more like the elderly are being weak in comparison for example, the young adult in the matter of their physical activity, the immune system. I think so. I don't know.
Yes, that's correct. That's correct. And actually, number 2 was the definition of frailty. So you could have. Thank you very much for your answer. Now at number 2 in the slides, you can see that frailty is basically described as patients being weaker, just as the doctor said, and more vulnerable than their age-matched counterpart. So basically, you would have, yes, it's elderly patients being weaker than younger population, but it also could be that two similarly aged patients having different frailty score. So one of them would be more vulnerable to side effects and more weak than the other person who is the same age. Okay. Now, this makes older patient more a little bit more challenging because of their vulnerability, and it makes it a heterogeneous population, meaning that you can never expect the same kind of result, the same kind of, let's say, a tolerance to treatment, even within those who are the same age, because variety is makes them a heterogeneous population. A 70-year-old or a 75-year-old, two 75-year-olds could have totally different frailty score, with one being more fit and the other being extremely weak. Sorry. Now, frailty is important overall in the geriatric population. However, it's particularly important in multiple myeloma. Sorry, my bad. A frail patient has reduced physiological reserve, and they were more because of their comorbidities and the oh my god, because of the different comorbidities they have, they can be more vulnerable to stressors such as infections, chemotherapy toxicity, hospitalization, and functional decline. Now, even though frailty is prevalent among the elder population, this does not mean that they should not receive proper effective treatment. Sorry, I can have a second. Okay. Instead of seeing a frail patient and withholding the treatment out of fear of them developing severe side effects or toxicity or having functional decline, instead of that, the frailty assessment should help us determine how intensive treatment should be and which toxicities we need to anticipate and prevent. In some cases, we can even reduce the intensity of the treatment or reduce the dose according to the frailty score. In other words, frailty assessment in multiple myeloma help us avoid both overtreatment and undertreatment of patients. It's also important to know that it does impact the survival and the progression of the multiple myeloma. And this will be focusing on more on the upcoming slides. Now, for us to assess frailty, there are a couple of scores that are available. One of them is the International Myeloma Working Group score, frailty score, or the IMWG frailty score. This includes three parameters, one being the chronological age, the other being the comorbidity index, specifically using the Charlson Comorbidity Index, and the third being the activities of daily living, or the activities of daily living, or the instrumental activities of daily living. This could allow us to broadly categorize the patients into their fitness as important in the classification of the prognostic and the therapeutic side as well. Now, frail patients, unfortunately, generally have worse progression-free in overall survival rates, and they experience more treatment-related toxicity. Now, the progression-free rate is basically when the patient has a static disease from the moment of diagnosis till after treatment. So patients, for example, have the improves and then stays the same for 1 year. That 1 year would be a progression-free period. And the opposite would be someone having the progress, the disease worsening much early, which is unfortunately common with frail patients. Okay, now there are also other scores, including the RMSI, the UK MRA. Those are additional frailty scoring systems. And they assess different aspects of vulnerability. The practical message here is that it's not that every clinician needs to calculate every score out there. Rather, we should note that we need structured methods of identifying patients who are particularly vulnerable before starting treatment. And it's important to note that, remember, the score should only support our clinical decision making, not replace it. Okay. An important, or let's say an interesting addition to frailty assessment in patients with multiple myeloma is what we call objective measurement of physical performance. These are simple tests such as grip strength, 4-meter gait speed, or the short physical performance battery that can provide us with useful information regarding the function of the patient. One interesting one is the gait speed, which is particularly attractive when it comes to assessing the patient because it's quick, it's inexpensive, and easy to perform in the clinic. You can go as much as saying that it deserves being added as a vital sign in a geriatric population follow-up. It would provide us with information that we cannot simply obtain by looking at the patient age or laboratory result, as we can assess their functionality, and how far they can walk and what's the speed of their gait. Okay, now let's assume that we examined the patient, we diagnosed the patient, we did the tests, we managed the acute emergencies if the patient had any acute emergencies at presentation. And then after that, we sat down with a multidisciplinary team to set the treatment plan of the patient. Now, a very important major principle in care of geriatric multiple myeloma is that the treatment goals need to be individualized. For older patients, maximizing survival would be the highest priority. For others, for some older patients, maximizing their survival would be the highest priority. For other patients, they would want to maintain their independence, maybe avoid hospitalization, maybe they would want to preserve their cognition and mobility, or some would even want to remain at home and be more, some would even want to remain at home, and that would be more important to them. Therefore, the patient should be included in his care plan, and we should know what's the most important goal that the patient would want. Now, other issues would encounter the patients, elderly patients or geriatric patients. Practical issues including transportation, caregiver availability, frequency of hospital visits, and the ability to adhere to oral medication. All those can influence the treatment that's realistically appropriate. So these are important points that we need to put in mind while putting a goal, treatment goal or goal of care when caring for elderly patients. Now, in multiple myeloma, the treatment, other than the emergency one, falls between hematopoietic cell transplantation or autologous transplantation with according to guidelines with chemotherapy before it, and then the transplantation, and then the follow-up, or for those who are transplant ineligible, chemotherapy combinations. Okay. First of all, for elderly patients, or in general, we would want to see what's the risk stratification of the multiple myeloma patient. And then are they transplant eligible or transplant ineligible? Starting with transplant eligible patients, we should note that historically, autologous transplantation was often considered primarily according to clinical age, with many centers using an age around 70 to around 77 as a general threshold. However, it has been debated that age alone is not an adequate measure of transplant fitness. And so, for example, a biologically fit older adult may tolerate intensive treatment better than a younger patient with substantial frailty and comorbidities. Therefore, a modern approach is increasingly based on biologic fitness rather than an absolute age cutoff, even though the age cutoff itself is not absolutely not effective. It has some effectiveness. However, sometimes you would find an older patient who is fit, so it may be beneficial to consider them even for our transplantation. Now, for the transplant ineligible patients, they are the variety of agents and combination that are available, such as the DRD, the daratumumab VMB, the VRD combination. Overall, the principle in multiple myeloma is that combination therapy is generally more effective than doublet therapy. This is when it comes to multiple myeloma in general. However, in the geriatric patients, efficacy has to be balanced against toxicity. So the regimen that produces the best response on paper isn't necessarily the best regimen for a frail 85-year-old patient. Therefore, a multidisciplinary team needs to choose the most effective regimen that the individual patient can actually tolerate. Now, there has been multiple trials that has experimented with effective medications, including the MAIA trial, the Acyclone trial, and the SWOG trial. Oh, okay. Okay, so for the, I'll just briefly go through them. For the MIA trial, it was established in this trial that DRD, the combination of daratumumab and lenalidomide and dexamethasone, has been more effective than the RD combination alone in transplant ineligible older adults. They delivered superior survival benefits without transplantation, and it achieved an impressive 93% response rate, although they did have higher incidence of grade 3 or higher neutropenia and infections compared to the RD combination. So they had more side effects. The Acyclone trial demonstrated that the DVMB combination, which is daratumumab, bortezomib, melphalan, and prednisone alone, were more effective than the VMB alone. So the addition of daratumumab was deemed more effective. Additionally, it explored the addition of subcutaneous daratumumab, which helped reduce clinic burden and travel strain for older adults. In this study, the DVMB combination achieved the 91% response rate, but it carried clinically significant adverse events as well, and that included neutropenia, thrombocytopenia, and infections. Now, the last trial we'll briefly look through is the SWOG S0777 trial, which established the superiority of the VRD combination over RD, proving significant survival benefits for older adults with multiple myeloma. Now, a very interesting aspect showed that the full dose toxicity being difficult for older adults to tolerate, Therefore, a recommendation favoring modified reduced intensity approaches, such as the VRD light, being effective to balance the efficacy of the treatment with the safety. So, although the VRD did improve progression-free survival in older adults, so the period of survival where the disease did not progress, right? That's the progression-free survival. The VRD did improve that. However, the full dose was difficult to tolerate. Therefore, they came up with the VRD light approach, which basically had a modified regimen, spacing bortezomib and reducing the lenalidomide dose. This has been investigated to improve tolerability. So the message from this is that even within the study that was made, the elder population were included to a certain degree, and even for some of the regimen, they experimented with changing the dose and spacing the dose so that the geriatric patient with multiple myeloma could tolerate the specific chemotherapeutic agents that they were receiving. Okay, so throughout the MAIA and the acyclone report, frailty was found to have a prognostic significance, but it did not necessarily mean the effective therapies stopped working. So subgroup analysis from those major studies showed that frail patients in general showed shorter progression-free survival. So they were more quick to for them to have the disease worsen again and progress again than the fit patients. However, it was important that even within the frail subgroup, those who received the DRD over the RD alone had better results. So even within the frail group, those who received specific the DRD had more benefit than those receiving the RD combination alone. Now, this leads us to a very important clinical message, which is even if the patient is frail, yes, you should consider how to treat the patient the best way, but you should not withhold the effective drugs simply because they are older or frail. Instead, as I said a couple of slides ago, a multidisciplinary team should consider modifying the dose, schedule, or supportive care according to available guidelines and evidence-based medicine so that the patient can have the best treatment they can tolerate and get. Okay, now, ideally, guidelines should be followed. However, ideal guidelines do not always match local resources. So sometimes in areas, in third world countries, in some areas, access to advanced therapies, transplant, or even molecular testing can vary. In high-cost medications, such as the newer four-drug regimens, frequently are limited by in availability or and their high cost sometimes limits the patients from being able to get them. So evidence-based medicine has to be flexible when it comes to these specific resource related problems, with an ultimate goal of delivering the best possible treatment within the bounds of what's truly available to the patient. Okay, now let's imagine that we sat down, we asked the patient, we put a treatment goal that's in favor of the patient's situation according to their frailty score and according to their overall score. We would expect some side effects from the treatment. However, I will not be going specifically through all of the oncologic, the chemotherapeutic agents, but I would like to give the spotlight to one specific medication, which is the dexamethasone. Actually, dexamethasone does deserve a particular attention in older adults because although it had been a very highly effective medication against multiple myeloma for more than 40 years, they can produce substantial toxicities. Older patients are particularly vulnerable to complications such as neuropsychiatric effects, metabolic abnormalities, muscle weakness, and infections. Therefore, steroid intensity should be carefully considered. In some studies, in some trials, it was studied. Um, they studied the possibility of lowering the doses of the steroid medication, sometimes as low as 20 milligram. And this showed some sort of reduced side effect profile, in addition to somewhat acceptable treatment criteria. So you should be very careful with the side effects, the possible side effects of dexamethasone with elderly patients. Okay. Now, after considering the side effects of the patient's chemotherapeutic agent and medication that they're taking, there are other supportive elements that we should also put in mind. One of them is the skeletal event. Supportive care, to be honest, is not an optional component of myeloma treatment. It's an essential one. And bone disease is one of the major causes of morbidity. Some agents could be given to the patient, such as anti-resorptive treatment, which can reduce the skeletal complication. However, you should be very cautious with renal function impairment in some medication, for example, the zoledronic acid, which is a prescription bisphosphonate medication. Other than that, we also need to monitor for fractures. An actual or impending pathologic fracture may require orthopedic intervention, particularly when long bones are involved. So even orthopedics sometimes are involved within the treating team of a multiple myeloma patient. The ultimate goal here is not to simply prevent fracture, it's to preserve the mobility and independence of the patients. Another supportive care element is infection prophylaxis. Now, infection is generally a major concern in older patients, specifically frail patients. And in this specific case, because the disease itself, multiple myeloma, can lead to immune suppression with the subsequent neutropenia and disease complication, it can lead to immune suppression. And this can further be compounded with further immune suppression from the treatment, making the patients very vulnerable to infection. In this case, we should consider vaccinations, including influenza, pneumococcal vaccines, and other relevant vaccines. And in select patients, in select treatment setting, some patients may receive antimicrobial prophylaxis where appropriate. Now, with the supportive care, we close this section with two final, but not yani, these are not the only complication, but we close with these two ones, one being the venous thromboembolism and the other being the neuropathy. The venous thromboembolism is a serious toxic side effect of some of the chemotherapeutic agents. So appropriate VTE or venous thromboembolism risk assessment and prophylaxis should be conducted to every patient with multiple myeloma. Additionally, the peripheral neuropathy is a non-side effect of bortezomib. It should be the patient should be examined for peripheral neuropathy because even though it starts insidiously, it can progress to affect the patient's walking, balance, and independence, which hugely affects patients' ability to do their activity of daily living. Some measures that can be taken or that has been shown to decrease the specific side effect is the subcutaneous using the subcutaneous route when administering bortezomib, and giving once weekly administrations. Active screening at every visit is recommended. Okay, now we took our patient, diagnosed the patient, took care, gave the full course, the 8 to 12 cycle course of chemotherapeutic agent for the transplant ineligible patient, or we gave the transplant to the patient and followed up with them. Unfortunately, even after immense efforts to treat, some patients can have relapse. So relapse is expected with multiple myeloma. If the patient has a relapse, the second round of treatment is usually highly individualized, and it has to do with what the patient received previously, what did they tolerate and not tolerate, what toxicities did they develop, what's their current comorbidity status, what's their current frailty assessment. And the choice is basically shaped by their prior experience. Okay, now on a more bright light, there are a lot of emerging therapies for multiple myeloma, including the bispecific antibodies and the CAR T-cell strategies, which represent the next wave of treatment in multiple myeloma. However, we need to be cautious when exploring the results of these therapies when it comes to frail older adults. And this opens a clinical question, and it opens an area of research to see if those therapies, the new emerging therapies, are actually appropriate for frail adults. So we still need to have better evidence to determine which frail patients can safely receive these intensive immunotherapies, and whether there is a level of frailty at which CAR T cells, the CAR T cell therapies, for example, becomes inappropriate. So this is an important area for future research. Now this concludes the presentation, and to summarize, I would like to leave you with 4 key messages. The first being that multiple myeloma was reported to have high prevalence in older adults in the US, and its importance will continue to increase as population age. The second message is a formal assessment of frailty, comorbidity, and physical function could play a vital role in predicting disease progression, expected side effect profile, and it would also help with individualizing treatment options. Thirdly, effective treatment should not automatically be withheld from older or frail patients. Instead, treatment intensity should be individualized and tailored to frail patients. And finally, supportive care is just as important as anti-myeloma therapy. Bone health, infection prevention, thrombosis prevention, neuropathy monitoring, renal protection, steroid minimization, those can all have major impacts on outcomes of older patients or geriatric patients with multiple myeloma. Ultimately, our goal is not to simply treat myeloma. Our goal is to treat the patient with myeloma while preserving their function, independence, and quality of life. Now, for references, there is an article that's named How I Treat Multiple Myeloma in Geriatric Patient that was published in the Blood Journal, which is very nice to see. And some of the information regarding the introductory slides I took from UpToDate. And then finally, there is the beneficial StatBros articles with their article in multiple myeloma. Thank you very much, everyone, for your attention. And although I don't have a lot of expertise in this topic, I hope you benefited Please, if you have any questions, feel free to ask. Thank you very much.
Dr. Sabry, you are muted.
Sorry, thank you very much, Dr. Nader, for letting me know. I would like to thank you very, very much, Dr. Amna. Honestly, since I entered the medical school and now practicing for +1 year, I haven't seen such a presentation about multiple myeloma, honestly, and even in the level of the R4 level. I mean, it was very extensive and detailed. Now we can say all that we are able to manage the elderly with multiple myeloma one day after specialization. Thank you very much, and I will let Dr. Nader to comment as well.
Thank you so much, Dr. Amna. This is excellent, wonderful presentation. You did great, and it's as you mentioned, it's a big topic, and you did summarize and present it in a concise format that is well done. So thank you so much. Great job.
Thank you very much.
Right. So our next topic will be the RevMan, which is a tool for systematic review and meta-analysis. This tool is and presentation is going to be presented by our fellow Dr. Roaa. If you are here, you can go whenever you're ready.
السلام عليكم ورحمة الله.
وعليكم السلام ورحمة الله وبركاته.
How are you all? كيف حالك دكتور نادر؟ إن شاء الله تكون بخير.
الحمد لله بخير. تسلمي. شكرا لكم كلكم. تفضل.
العافية يا رب. Okay, today I'm going to present RevMan. Okay, just 1 minute. I will share the screen. Can you see my screen now?
Not yet.
Okay, 1 minute. Okay, is it clear?
Yes, it's now visible. Yes.
All right. Okay, I would like to present RevMan, which is short for Review Manager, and okay. So RevMan, it's short for Review Manager. It's the official software developed by Cochrane, and it's the standard tool used worldwide for preparing and maintaining systematic reviews. And okay, they are it helps you manage data, run statistical analysis, and generate reports all in one place. Am I audible?
Yes, we can hear you.
Okay. Next, it follows strict Cochrane methodological standards. And the last, because it's cloud-based, there is multiple people or participants can work on the same review at the same time from anywhere. So in short, it's designed for collaborative and high-quality evidence synthesis. Okay, when and why do we use RevMan? When we use RevMan, okay, first we use it to conduct systematic review of interventions or diagnostic tests. Second, we use it to perform meta-analysis, which is combining multiple results from multiple studies. And we can use it to create Prisma flow diagram and forest plot. Okay, and the first is a standardization, which is automatically follows that you don't need to write any code, not like XR or Stata. And the third one, which is a collaboration. It's a real-time multi-author editing is built in. And we'll show later how to collaborate with many participants. So as the code here on the slide says, RevMan lets you focus on interpreting the evidence rather than fighting with complicated software. Okay, so the core philosophy, which is study-centric data, this is one of the most important concepts in RevMan. The traditional software often forces you to enter the same study information again and again for every outcome, but RevMan uses a study-centric data approach, which is you enter data for the study details once. Then the single study can feed into multiple outcomes and for the risk of bias assessment as well as in the analysis. The benefits, it will be much more efficient when you enter in information only one time, and it will be greater consistency. So the same data appears correctly everywhere. And also there will be fewer transcription errors. You can think of it as organizing your data the way research actually works. So around the study, not around individual outcome. Okay, we can go to the key features of RevMan Web. Here are 4 features that students particularly appreciate. The first one is a real-time collaboration, and it's when several authors can edit the same review simultaneously without version conflict. They can edit anytime, and each of them can work in separate part. The second one is the risk of bias tool integration. It's a built-in template for the last risk of bias tool to use assessment easier. The third one Grade Pro for creating professional summary of finding tables. Okay, and the first one is the automatic analysis. When you run the analysis, you will find a forest plot and funnel plot. It will be updated instantly as soon as you enter new data. And these features turn RevMan into a complete workflow hub. So rather than just a statistic tool, not like a CMA, the comprehensive meta-analysis, or R. This is a quick recap for GRADE. It's a grade and recommendation assessment, development, and evaluation. It's an approach to formulating the evidence-based recommendations and through a transparent and systematic process with an explicit link between evidence and recommendations. Okay, for the workflow, there will be 2 parts. The first part, it's a plan and a prepare. For the planning phase, we use PICO as a framework. PICO P is for population, who are the subjects, and the intervention, what is being tested, comparison, what is the control, outcome, what are we measuring. Also, you set up your risk of bias domain early. Next is the preparation phase. Import your reference. And also you can create extraction template. So every team member collect data in the same way. And yeah, here as it's a well-planned control in RevMan. It saves a lot of time and prevent mistake later during analysis. In workflow part 2, to populate and analyze. Once planning is done, you move to data entry and analysis. Okay, so first we transfer the results into the study-centric structure, as we said earlier. For example, in dichotomous outcomes, which we have when we have a yes or no, or we have male and females, we enter numbers of events and the total participant. Whether when we have a continuous outcomes, we enter the means, the standard deviation, and sample size for all the studies. The fourth step is analyzing the results. We choose a statistical model. We choose either fixed effect or random effect. We choose it based on the heterogeneity. So RevMan automatically generates the force plot, which is a visual summary of the results, and the funnel plot to check the population bias. We will show it later on. So the first plot becomes the heart of your meta-analysis. It shows the overall effect at a glance. Here we have example. It's a real world example for vitamin C case study. Let's look at a real example. So you can see the first plot. So we'll explain first this diagram. When we find the square represents one study. The size of the square shows how much weight that study carries. Second, when we find the horizontal line is the 95% confidence interval. Shorter lines means more precise results. It's vertical line, no effect. The result is statistically significant. And hopefully we'll find it like that. So in this famous vitamin C reviews by the researchers, they found they make 29 trials people, and individual small studies were inconclusive, but the meta-analysis showed a clear reduction in cold duration. Results and making analysis will show like different results. So here it shows it is statistically significant. Okay, here I make a quick review of how we make it. It's a practical. Log in with your institutional or individual access. This is the first page you'll find. Go to my reviews on it. After that, you choose my portfolio. We will go to my reviews. Okay, and set it. Write your research title. That's intervention here, and in the template you write. Second, and if you have organization access, you write your university, and then the template. Add review, it will be like this one. You can choose this one. Can I have just one moment? Hello? Well, Hello?
Dr. Roaa, are you speaking with us or?
Hello?
Can you hear me?
Hello?
Yes, Dr. Roaa, we can
Hello?
hear you.
Okay, sorry for that. Okay, so we're here in the first part. So after writing the title of your study and then the type of your study, which will be mostly intervention, and the organization name, and then the template, which will be the same as the title name. Okay, and go next. Okay, so just as a note, in RevMan Web, we assume that submission to the Cochrane collaboration. So normally it will requires you to add your contact details, the planned update, the dates, and the completed background and method section, as well as the protocol development. Okay, so move here next. After adding your title, it will be showed here in the screen. You add it. For example, its name is nutrition supplement for the elderly. You will find this one after adding your organization and the subject. This is in the review criteria. After that, you will go to add your outcomes. So if you have dichotomous and if you have dichotomous or continuous, you add the name both here in the outcome section, and it will be showed like this. And then you go to your studies. You add all the studies you have in the studies, and include the studies. You add it all here. Then it will be showed in your screen like this. You have the supplement versus the control, which is binary and continuous outcome. Okay, and if you want to edit your outcome, so it will be easy just by clicking here. After that, you click run analysis. It will be showed like this. All the analysis in this screen, we didn't add the numbers for the event total, but it's just an example of how it will be showed to you. So if you want to edit as well, you can edit analysis here, and then you can add data if you want to change anything. The status will be showed here like this, and after pressing OK, for each study, after adding your numerical data, number of events, and the total for your studies, all of them will be showed here. Now, because we didn't write any numbers, it's just zeros, but for you it will show all of it. Okay. This is for the continuous outcome. Okay, so here the adding analysis is the same process for the continuous data and the dichotomous data. It's just a review. Okay, here's an example of how we collaborate with the team. So first you click on portfolio, then all your studies will be showed here. For example, I choose a nutrition study. interface, you will find all these options. You choose the manage authors. After that, this screen will be shown to you, your name, and then here you write. It automatically then he can go to the review directly. Okay, here as like student survival kit for the access, if authors, you will have free access for the individual study by subscription or free trial. Okay. This is for the conclusion, the key takeaway. Impressing in SCD, as we said earlier, it will save you a lot of time after you understand it well, and it will have, of course, max efficiency. And you should utilize real-time collaboration to work effectively with your research team. And also, you should focus on visual interpretation through automatically generated force plot. And that's it. Sorry for going like a bit so far. So if you have any questions, please.
Thank you so much, Dr. Roa. This is also excellent presentation and demonstration for how we can use RevMan.
Thank you so much, Doctor.
Thank you very much, Dr. Roa, for the presentation, for getting us familiar with the RevMan tool for systematic review and meta-analysis. Hopefully, inshallah, we will have some ideas to work on as a hands-on practice.
Dr. Roa, if you can share with us your experience or your how long you've been using it, or what institution you joined. Thank you.
Of course. Yes, of course. Thank you, Dr. Nadia. Actually, I have been working since 2020. After graduation, we started learning and practice with our doctors in the university. They showed us how to use like many tools, and this was one of them. But it was like many of the things that we studied, it was like not very deep. So after that, I joined many courses in Coursera, and from my master for public health.
Sorry, your voice comes and goes, so can you repeat the last sentence? Thank you.
I used RevMan in right now till 5 studies. So with time, it's become easier to use it, and I'll be happy.
We can't hear you, Dr. Roa.
So we can learn from each other. Yes.
Sorry, but also
audible?
now the voice has goes and it comes back at the end of the sentence.
I'm really sorry for that. Yeah, I said that right now I'm MPH scholar in Aberdeen University, so we are learning this more deeper. And I collaborated and in like 5 research used RevMan, and I'm really happy to like learn from each other, and anyone if they want to learn something in RevMan or CMA or R, I'm really good at this, so I will be more than happy to share and learn from each other. And yes.
Dr. Roa, can you, for example, suggest or recommend any, for example, introductory courses for the RevMan use, for example, on Coursera, the one that you used, or any, for example, reference YouTube channels that would help the
Yeah.
colleagues and fellows to be more familiar with the RevMan?
Yeah, of course. There is course in Coursera, and I think also Harvard has a really nice course for RevMan, and I will share the link in the group, of course.
Excellent. Great.
Yeah, I appreciate it. Thank you so much.
Thank you very much.
Thank you.
All right. So our next topic will be with Dr. Nadia. Yes, with Dr. Nadia, if you are here.
Yes, assalamu alaikum.
Walaikum assalam wa rahmatullahi wa barakatuh.
Good afternoon, good evening, everyone, wherever you are.
Good
I'm
evening.
Dr. Nadia, and I'm going to be introducing or displaying Jane, a journal finder. Let me just share my screen. Okay. Is my screen visible?
It's visible.
It's visible. Okay, thank you.
Welcome.
Okay, so this is Jane, an online tool basically for to help you find the right journal for your research. We know how important it is to choose the right journal when you are trying to publish your research. So it is an online, free, very easy to use platform where you insert your title or your abstract of your manuscript, and it can help you find journals, find authors, or find articles. So let's say you have your manuscript, you have everything ready, you are trying to get published. One challenge you'll face is that there are thousands of journals. They all have different aims, different scopes. It would be a waste of time and a waste of money to be trying to applying to different journals that may not be fitting for your title or your topic. So this is where Jane steps in. This is where it helps. So we are going to be using as an example, a poster that was presented before, right? And so all you do is you insert your title or your abstract. You can also use keyword search, so only inserting keywords. We will come back to that. So you copy and paste it, and then what you were trying to find is where you head. So if you're trying to find journals that will be suitable to publish in, then you can do that. You can also find authors with published work similar to yours. For example, if you'd like them to help edit or review your work, you can also find articles similar to your text that you can cite from. If you're trying to find a journal. Okay, so this is what we have, and it shows you basically the different journals. And one thing to note is that it is based on PubMed, so it uses it will compare your text or your document to documents that are in PubMed or Medline indexed. And there's a side of the confidence bar basically ranks similarity scores of all the articles. So it helps you understand the level of similarity between what you have input and with these articles in these journals that they suggested for you. So the higher the confidence, the more similar articles in this specific journal are to the one that you are trying to publish, let's say. And then you have the article influence, and this measures how often this journal, the articles in this journal are cited within the first 5 years after they have been published. So it basically shows you how popular or how good some of the articles in this journal are and the weight that they have when it comes to citation. And so, for example, our poster was about the effects of anesthesiology on postoperative cognitive dysfunction. So it's giving us a few journals here. You can see it's, you know, the less similar they are to yours, the more they'll be at the bottom. But the ones up top are the closest to what you're looking for, basically. So, for example, we have Frontiers in Aging Neuroscience is a journal that is found in PubMed, and it's high quality and open access. And then you can go and see the articles that are similar to yours in this that have been published in this journal, basically, that you can and their citation. And then you can go and click on each one and just read through it. But what you're trying to do here the most is find the journal that is likely to publish your work for you. And then with the same thing, you can, let's say, find authors. If you click on find authors, it will give you the same thing, but it will give you names and sometimes emails of authors and their articles who have published something similar to the topic that you have, that you are trying to publish. And then you can also do the same thing with finding articles where it's similar to PubMed. You are just looking for articles similar to yours that you can also cite or use. Also, sometimes use them for novelty. Like you can tell that if you are trying to publish and many people have published something very similar to yours, then it's not that novel, then it might not be the best for this journal, for example. And then, as I said, Jane relies on the data in PubMed, which can contain papers from predatory journals. So these are only recommendations. They are not guarantees. So you would still have to check the scope of the journals. You would still have to check author guidelines and verify publication fees. So it is very helpful to find, let's say, a journal that you can reach out to and try to publish. Like it will basically narrow down the number of journals that would be more likely to publish what you are looking to publish. But you also have to do your own careful journal evaluation before just going for it. And it's a very simple tool, so that is all. It's a very short talk, unfortunately, but there's not really much more to it. Yes, the keyword search is very similar. So you can say, for example, you can just look up malaria. Let's say if that is the keyword that you're looking for, and it will do the same thing, where it will give you journals where, let's say, topics related to malaria are mostly published by these journals with their article influence, and you can also see the articles and everything. That is all there is to it. Thank you. I would also like to mention that this poster, I think it is, if any of the fellows would like to, I think, be interested in writing a paper out of this poster, it is available, I believe. Thank you. Is it still sharing? Hello?
Thank you very much, Dr. Nadia. This is really interesting tool. This is the first time for me to encounter Jane Journal
Me
Finder,
too.
and it's easy and simple and straightforward to use it. We can
Yeah.
tell from your presentation. Thank you very much for the presentation. Would you please come again with the poster part, the manuscript
Oh,
writing?
yes. Yes. Sorry, what are you asking for exactly?
You mentioned that the poster is available for, I think, manuscript writing.
Yes, this was, I think, written on the agenda that if fellows are interested in writing a paper out of this poster, it has been presented before. It should be on the application.
So just for the fellows to be to
To be informed,
understand
yes.
very well, are you planning, for example, to write a manuscript and you are looking for co-authors also, or you?
No, I am just informing everyone, but I would like to.
I see. So if, for example, one of the fellows want to write the manuscript about this poster, they
Yes,
would
exactly.
contact you, right?
Yes, and I can send them the poster.
All right, great. Thank you very much for this opportunity. This is a great opportunity for our colleagues, fellows. If you are interested and you are, for example, applying for any residencies in the next cycle, whether in the US or abroad, you can use this opportunity to write the full manuscript for the poster shared by Dr. Nadia. You can contact her directly, and you may be able to publish the manuscript, the full manuscript.
Okay. Thank you.
All right. Do we have any questions so far?
Thank you so much, Dr. Nadia, for excellent presentation as well, and the demo of the
Thank
GEN.
you, Dr.
It's a
Nadia.
very useful tool, and when fellows finish writing or before even finish writing a manuscript, and then they can use this tool to identify which journal they can approach, and as you mentioned, they can verify and see what the cost and the impact factor and so on. Thank you so much.
Thank you very much, Dr. Nadia.
One more question for you,
sorry.
Dr. Nadia. Did
Yes, sure.
you publish, or
Sorry?
do you have any projects, like you have any published posters or papers or anything like that?
Oh, no,
Thank you.
sadly not yet.
Sure. We'd like to use this manuscript as a starting point. You can create a team, and then you can ask for help from the seniors if you want to.
Okay, I will do that for sure. Thank you so much.
Sure. Thank you, Dr. Nadia.
So, next presentation will be about the patient satisfaction. I'm going to share my screen now. Can you see my screen?
Yes.
All right. So this is fortunately was one of the presentation that we presented for the intern doctor orientation in the internship year training, and they just added some of the additional points that might be of interest for our colleague fellows who are going to apply for the residency and hopefully got match in the US in the upcoming cycle. So the patient satisfaction is sometimes understand the interns or junior doctors understand the patient satisfaction as the patient experience. Although they are very related to each other, they are not the same. So what we need to know as a junior doctor or resident is to know what is the definition, what is the patient satisfaction in the first place, right? To differentiate between the satisfaction and also the experience of the patient. What is the objectives of patient satisfaction? Why we are stressing on the patient satisfactions, and why it's matter to the patient as well as to the practice for you as a junior doctor and also as a specialist level. So the learning objective by the end of these sessions, you will define the patient satisfaction and distinguish it, as we said, from the patient experience. You will explain why patient satisfaction matters clinically and professionally, and also for the hospital-wise or the clinic-wise. Identify the key drivers of satisfaction that are within the physician's direct control, and recognize common communication pitfalls new resident can make on the ward or even in the clinic. Apply practical and evidence-based habits to improve satisfaction in daily practice. So the definition of the patient satisfaction is it is the degree to which a patient's expectation of a healthcare encounter are met or exceeded. So it's judged by the patient. So this means that for example, for one type of healthcare given to a patient by the same healthcare provider, it might be evaluated differently, although the care was the same and also the provider was the same, right? But here the difference is only in the patient's perspective. So this might result in a different evaluation or different expectation from patients, and this will result in a different patient satisfaction eventually. So the key characteristic is that it is subjective, right? The patient satisfaction is subjective. and it reflects the patient personal judgment. It's not an objective clinical measure, so it's not a standardized tool that can be used over all clinicians and as well as over all patients as well. It's expectations based, so it's shaped by what the patient anticipates going on. So, for example, one of the patients came to the emergency room, and then they was admitted to the inpatient ward, and they were, for example, expecting to be, for example, discharged within the same day. And the treating team or the healthcare team encounter, for example, a finding in the history of physical and lab findings that might need the patient to stay for a few days, right? And the patient expectation was to be discharged on the same day. So this will affect the patient satisfactions, but we do have, as a clinician, as a healthcare provider, techniques, maneuvers, and behavior that we can do in such situations to better alleviate the patient's anxiety, worrisome, and also to improve the patient satisfaction. Also, the multimodal dimension covers the communication, environmental coordination, and outcomes. So a note to terminology that satisfaction is not the same as a quality of care. The patient's quality of care could be 100% accurate, but the patient satisfaction isn't, right? So a patient can be satisfied with a visit and still receive a suboptimal care, right? So the care or the quality of care itself does not reflect necessarily what is the patient satisfaction would be, and also the vice versa. So satisfaction should inform but never replace the clinical judgment. And we have a lot of clinical measured nationally through the in the US. This is in the US mainly, which is known as HACCPs, which is the Hospital Consumer Assessment and Healthcare Provider. And also we have CAPS, which is the Consumer Assessment of Healthcare Provider and System. What is the difference between them is that the HACCPs is hospital consumer. So mainly it's a type of a survey that is used for the patients to evaluate the communications, the service, and the communications, the behavior, and also the service was provided in the hospital. While the CAPS is more broad, so it can be used for patients as well as for clinician. We have also the AHRQ, which is the Agency for Healthcare Research and Quality. And this agency is mainly in the US to build the research to improve the healthcare safety, right? So these types of tools are used in the evaluations of the patient satisfaction and also on the outcome of the healthcare services. So what is the difference between satisfaction and experience? The two related terms are often used as interchangeably, but they are not the same. So the patient experience, it's what actually happened, right? What actually happened to the patient. So it is objective, it is not subjective, right? While the patient satisfaction, it is subjective. So it can differ, although as we've mentioned at the beginning of the presentation, it was the same care and it was the same provider for two different patients, but the satisfaction differs significantly between them, right? Because it is subjective, not objective. While in patient experience, it's objective wise. So did the intern, for example, introduce themselves and their role? This is considered patient experience. Was the pain addressed with a reasonable time? This is also considered patient experience. Were test result explained before discharge? Can be directly improved through your behavior. So the patient experience can be improved with practice. Let's see in the other side, the patient satisfaction. So as we've mentioned, it's a subjective judgment. So it differs from one patient to another, although for example, hospital care or quality of care was the same. So it is colored by prior visit, culture, personal expectation. Two patients can rate the same care differently, as we've mentioned, and influenced by how care was delivered, not what was delivered. So how the care was presented or given or delivered to the patients will affect the patient satisfaction, but not what was actually delivered. What was actually delivered, it is the patient experience. So as an intern, I would say, or as a junior doctor in general, I would say that we should focus on the patient experience, right? So we should focus on the patient communications, on explaining the procedure, explaining the laboratory finding, explaining the differential diagnoses. And then in case of, for example, breaking bad news and the definitive diagnosis, This is for sure should be for more senior level, either the senior resident or the attending consultant. So if you focus on the experience and the communication skill with the patient, then the satisfaction will follow, right? Once you master the experience of the patient, you are a good communicator and you know how to listen carefully to every patient and to explain everything in a normal language, not a medical language, then the patient satisfaction will follow your patient's experience. So why does the patient satisfaction matters? First of all, the clinical outcome, right? It is associated with better adherence. So, for example, if a patient A is convinced and he is has a good patient satisfaction, he has a good experience in the first place with you, and then the patient satisfaction was good, then you would expect such a patient to be more adherent to the treatment plan, fewer complications, and lower readmission rates because they will listen to your orders and your treatment plan very well. Like they will trust you at the end of the day. The patient safety is very important as well. Patients who feel heard are more likely to disclose the symptoms and ask questions and flag errors. So if the patient feels that you actually actively listening to them and you have the empathy for them, then you will expect such a patient to be more open and they will ask you questions if they in the first place didn't have this relationship, they would not ask such a questions. And these questions would be, for example, questions that might relieve new symptoms or new complications, and it will change the treatment plan for them and eventually the clinical outcome. Your professional growth as well. It's very important for you. The communication and rapport building are a core ACGME competencies assessed through the residency. So this is for USE, for US residents, that the professional growth is they look at your communication and rapport building very well, and this might open for you new doors in your first programs and then in the fellowship programs as well. And then the organizational impact, the hospital reimbursement, public rating, and malpractice risk are all linked to how patients rate their care. So it's all a chain which is connected to one and another. If the patient's satisfaction was good, then the patient's safety and clinical outcome would also be a good. And then your own professional growth, your own reflection on the hospital would also be a good as well. And then the organizational or the healthcare setting that you are working in will have a such good rating as well. And then we have also the tools that we've mentioned earlier, that how the patient's satisfaction is measured. You don't need to memorize it, just you have to know it exists and why your daily interactions feed into it. First, we have the HACCPs, which is the Hospital Consumer Assessment Healthcare Provider and System. It's a standardized CMS survey sent to discharge hospital patients. It includes items on communication with doctors and nurses, responsiveness, and discharge information. So it's mainly used for patients post-hospital discharge. Then we have CAPS for clinician and group. This is a clinic-based survey for outpatient and specialty visit covering access, communication, and office staff courtesy. Then we have the internal routing on feedback, and this is usually would be an internal real-time patient routing from the hospital that you are doing the residency or the internship in. All right, so we have the key drivers within your control. So the national data consistently identify these factors as the strongest predictor of the satisfied patient. So there is some factors or key factors that you have to keep in your mind that would improve significantly and affect strongly the patient satisfaction. The first one is that the clear communication. Explain for the patient the diagnosis. Explain the patients what are you going for, starting from the beginning. Once you have to introduce yourself, taking the patients the wiper approach. If you remember from the tally reference, washing your hand, introducing yourself to the patient, taking permission, ensuring the patient privacy, exposing the patient accurately and appropriately only for the that the part you are going to examine, explain what you are going to do for the patients, and so on. So all of this is considered part of the clear communication. And then after that, you will do for example, the physical examination appropriately, and then you will tell the patient what have you found in your physical exam, and then the laboratory studies that you would like to order. And also you have to notify them. It's better to notify them with the result sure after informing the consultant or attending, better than to send the result with the nurses. And then empathy and respect. You have to listen fully before responding and acknowledge the concern and fear. A lot of the patients, they don't have, although we currently in the AI era, they don't have the courage or the, even here in the Middle East, the, let's say the understanding of the AI very well. So they don't use it. So although if they use it wrongly, the AI and the Google might, for example, give the patient a very wrong diagnosis, and then the patient will work and worry and have an anxiety for such finding on the internet. So you have to listen to them carefully and acknowledge their concern and fears, and then you have to respond, right? So the responsiveness, you have to address the needs and call button request promptly, even if just say you are on your way. If you are, for example, in ward patients and you are showing a different patient and the patient is calling for you in a different room, then you have to be responsive for them. Care coordination, keep the team and the patient aligned across shift and also hands off. So whenever you have done your shift, for example, in the morning, and you are handing the patients to the evening or noon shift, you have also to coordinate very well between the patient and the doctors. And then shared decision making. Whenever it's possible, please inform the patient and involve them in the treatment plan whenever it's possible. We have the practical communication framework. So this is regarding the communication framework that is used usually in the hospital setting, either this one or the Viber approach. You have to acknowledge, greet the patient by their name, and make an eye contact before anything else. Introduce yourself to the patient. For example, hi, my name is Dr. Sabry. I'm going to be the doctor resident from internal medicine department. I'm going to be today with you, and I'm here to do so and so. And then the duration, give a realistic estimate of how long test or wait would take up for these patients. For example, the patient that we've mentioned, he was admitted from the ED to the inpatients, and you found with the healthcare team that the patient should stay in inpatient for a few days. You have also to estimate how long the patients will stay with you. Explanation, explain why are you what are you doing to the patient and why, in a plain language, not in a medical language, and also thank the patient eventually. Also, there's a common pitfalls for new residents that you have also to watch and avoid while you are in your intern year or in your junior level, which is talking not with the patients, using jargon or rushing through explanation without checking understanding. So you have always, when you're explaining to the patients a procedure or a finding, you have to sit with the patients, talk with them, explain with them in a plain language, and then ask them if they have any questions. And after that, you have to ask the patient to repeat what have they understand from your talking. Skipping introduction on round. Patient often cannot tell who is who. So whenever you're doing rounding and you are the responsible for such a patient, you have to restate who are you and what are you doing. So I'm Dr. Sabry, and I'm the junior resident here in the internal medicine department, for example, and I'm responsible for your case. And this is the team with me, Dr. So and so and so. And then sitting and standing. It's very, very, very common for the rounds to be on standing because, and we understand this because we have a lot of patients and we have a lot of duties and responsibilities to do. So usually the rounding will be as a standing. But please, whenever you are able to, for example, you are not in round and you are just checking on the patients pre-rounding in the early morning, please have a seat with the patients, even if it's a brief sitting. Not closing the loop ordering a test but forgetting to follow up on results. So always when you ask the patient that we are going to do or run some test for you, please come again for them with the result of the test, what you found. And also treating satisfaction as a separate from care. Good communication is not as add-on task. It's part of the clinical care, right? All right, so we have also the practical habits to start today. So a small, consistent behavior compound into a noticeably better patient experience. First, you have to knock and announce. You have to knock before entering the room of the patient, even if it is a shared room, because this is their private area. And you have also to teach back, ask the patient to repeat instructions in their own words. And this is especially done for a newly medications given a patient who's going to be discharged. So you have always to check how they're going to take, what is the frequency, what is the dosages, is it pre or after meal? If they do have an injection, where is the injection site? For example, for the inhaler, let them show you how they are going to use the inhaler, especially for asthmatic or COPD patient and so on. So you always let the patient teach you back what they have learned. Whiteboard update, you have to update the care and the team name. Also set the expectation early, tell the patient what the day or discharge process will be looking like, and also follow up personally, return with the result as we mentioned. Better you personally goes to the patient and tell them the finding or the result instead of the nursing team. Debrief after hard conversation, check in briefly after delivering difficulties, news, or complex plans, and this is usually for senior levels. What happens when satisfaction is low? So poor experience carry a real consequences. It's affect the three essential panel for this talk, which is the patients, the care team or the physicians, and also the organization, which is the hospital setting, right? So for the patients, this will result in a lower trust, reduced adherence to the treatment plan, reluctance to seek future care, disclose any symptoms honestly. So all of this will affect the patient care eventually, right? And this will affect the caring team or the healthcare provider as a formal complaint, a lower moral and a strained relationship across nursing and physician staffing. And the organization or the hospital will have a reduced reimbursement, lower public quality rating, and elevated malpractice and litigation risk. So satisfaction should never override sound clinical judgment or patient safety. The goal is to better communicate, not simply pleasing the patients. All right, so this is the key takeaways. The patient satisfaction is a patient's subjective judgment of whatever care met their expectation. It's distinct from but related to the patient experience. And as we've mentioned, if you have a good patient experience, if you spend a good time and a communication with your patients, the patient satisfaction will follow your patient experience. It matters for clinical outcome, patient safety, your professional development, and also the organization or the hospital performance. Communication, empathy, responsiveness, coordination, shared decision making between the healthcare provider and the patients are the drivers most within your control. So if you are working on your communications, in your responsiveness, empathy, and coordination between the shifts, then you will have a good patient satisfaction. Simple framework like Edit or Viber that will be used in the communication skills in the introductions once you see the patient first time, and also the teach back can meaningfully improve every patient consumer. Good communication is part also of good clinical care, not a separate task competing with it. Thank you very much. If you do have any questions or you would like to discuss any point, please feel free to open your mic.
Thank you so much, Dr. Sabry, for also great presentation. And this topic, I think, it needs just to be used as Dr. Sabry mentioned, as an added value to your care. And in fact, the history of patient satisfaction comes as quality measures are used for reimbursement here in the US. For example, in the clinic, when you see patients, you will get rewarded by the insurance if you get good satisfaction. The same with hospitals. So the hospitals will get some reimbursement depending on the patient satisfaction as well. So I'm working in nursing homes. We also get reports from the nursing residents as their satisfaction and how we can make their lives better. And these scores will be recorded and reviewed by the state when they do their evaluation. So it's not only the impact of the effect of your caring for that patient and their experience and feedback for you, but also it can mean something else for your practice, your clinic, your hospital, or in my case, the nursing home I go to. Thank you so much, Dr. Sabry.
You're most welcome, Dr. Nader. Thank you very much.
We can move on to the last topic.
All right, so the next presentation will be with Dr. Alara.
Hello, hi everyone. I hope you're all doing well.
Hi.
I'm just gonna share my screen. One second. Is my screen shared?
Yes.
Okay. So my name is Alara, and today I'm gonna talk about a topic that actually seems very simple, but it's can be extremely difficult, which is the courage to say no. So we usually think of no as something negative or something like a rejection, disagreement, and maybe even conflict. But there are certain situations where saying no is actually the more responsible choice. And so sometimes saying no is important to protect our boundaries, our safety, or even the safety of other people. And I just want to start with a story that gives us a bit of an idea of how powerful no can be. And this story is about Dr. Frances Kelsey. In 1960, she joined the FDA, and one of her major assignments was reviewing an application for a drug called Kivadon, which is thalidomide. And at the time, this wasn't like some obviously dangerous drug. It was already being used in many countries and it was popular. And so the company expected the approval process in the United States to be relatively straightforward. And so there was a lot of pushing and pressure on her to simply say yes. And it's also beneficial to mention it was one of her first days on the job. But when she reviewed the evidence, she noticed something important, that there were still unanswered questions about the safety. And so instead of assuming that because everyone else is comfortable with it and many countries are using it, she should be too. But instead, she asked for better evidence. And this is where her first important no happened. And so there were several things that concerned her. So the available studies didn't really answer all of the important safety questions. And the response that she received when she asked the company didn't really fully resolve those concerns. And more importantly, since this drug at the time was used for morning sickness in pregnancy, she noticed that there wasn't enough evidence regarding fetal safety. And so her response was essentially very simple. The evidence was not sufficient. And I think that sentence is very important because she wasn't saying no just to be difficult, and she wasn't saying, no, I don't like this company or I don't like this drug. Her no was based on a standard. And she was saying, I don't have information to responsibly say yes. And of course, saying no was not easy. And that's actually what makes this story relevant to us today, because saying no wasn't comfortable for her. The company challenged her a lot, her decision, and she continued to tolerate that pressure. And that brings us to the question I want you to all think about today, which is, would you still say no if everyone around you believed you were wrong? Because we all know that saying no when everyone around you agrees with you is easy, but the difficult kind of no is the one you have to maintain even when everyone around you disagrees, or when your senior or your colleagues are disappointed in your judgment. Later on, thalidomide slowly, many cases started appearing worldwide about the abnormalities. And because it wasn't formally approved in the United States, the country avoided a big tragedy. And suddenly, what may have initially looked like it was stubbornness or unnecessary caution looked very different to everyone. And the first idea I want us to take from the story is that saying no, it's not always a rejection. Sometimes it's protecting, whether yourself or someone else. And of course, saying no doesn't always, or being able to say no or having the courage to say no, won't always be at this scale, but the principle behind the decision applies to everyday life. So if we remove the historical context for a moment, what does this story actually teach us? So first of all, popularity does not guarantee correctness. Second, pressure should never replace our own judgment. Third, saying yes also has consequences. So we often think about the consequences of saying no or refusing something, but we don't usually ask ourselves what happens if I do agree. And finally, a responsible no can protect people, our values, and ourselves. So now we want to take it away from the story and we want to make it a bit more practical. So we want to discuss, how do we make saying no a skill? Before talking about how to say no, we should understand why we struggle with it in the first place. And usually the problem is that it's not that we don't know how to say the word no. We know how to say it, but we're afraid of what comes after the word no. So we don't want to disappoint anyone. We don't want to be judged. We don't want conflict with someone who has authority over us. Sometimes we're afraid of losing an opportunity, and sometimes we feel guilty for saying no. So we say yes when we actually want to say no. And that's why the idea of learning the skill of saying no is very important. And learning the skill of saying no is also learning how to live with the discomfort and judging and trusting your judgment. Because every unnecessary yes is also a no. So if someone asks you to do something that you actually don't have the time or capacity for, you're saying no to yourself. You're saying no to the quality of work of your work. And so sometimes it's a good thing to ask yourself, what am I giving up by saying no to this certain task or to this certain thing? Of course, this doesn't mean that we should start saying no to everything. The goal isn't refusal for the sake of refusal. We're talking about a responsible no that usually protects us or someone around us or our values or boundaries. So, for example, when something is unsafe, when it violates your values, when someone crosses your boundaries, when you genuinely don't have the capacity to do something well. And it can also be necessary when you feel like you're being pressured, when saying yes could damage your health, or especially when a request is unfair or unethical. So now we're going to take it a bit more in a practical way. So for example, saying no at work. So if someone tells you, can you take on this extra task by tomorrow? But you genuinely can't. And a lot of us immediately want to say yes, especially if it's coming from someone senior, because we want to show that we are able and we want to show our best. But if you genuinely don't have the capacity to do something well, instead of saying, no, I don't want to, you can say, I understand that this is important, but I cannot take this on and complete it properly by tomorrow. And what this sentence does is that it's not attacking the request, it's not being defensive, you're just acknowledging that it does matter while also being realistic about what you can deliver. And so a professional no can actually show responsibility because you're not promising something you can't do properly. Now, of course, this isn't just limited to work life. Saying no to family and friends is also very important. So if someone says, just do this for me, it won't take long, you can say, I care about you, but I'm not able to help with this right now. And that doesn't mean that you don't care about this person, but caring about someone doesn't mean agreeing to every request. Saying no to authority, and this is probably one of the most uncomfortable situations. Especially that usually when it comes from authority, it's a bit more like, yeah, just approve it. Everyone else is okay with it. And this is actually very similar to the story we talked about. And instead of taking it personal, you can move the conversation back to standard. I understand the urgency, but I'm not comfortable proceeding without enough information. That wording is useful because you're not saying you're wrong and I'm right. You're not taking it personal. There's just a standard that needs to be met before I can agree. And in professional settings, especially, focusing on evidence, quality, and safety to form your boundaries is much more stronger than focusing on personalities. Now, saying no to yourself. I think one thing we also forget is saying no to ourselves. So saying no to overcommitting, to comparing, to guilt-driven decisions. So just saying yes and then feeling guilty about it and ignoring your limits. So how to say no politely? So once we've decided to say that we need to say no, how do we actually say it without sounding rude? I think these four steps are very useful. So first, we want to acknowledge the person or the request, and then we want to give them a clear answer. So one thing we do is that we don't want to say no, and so we say maybe I will be able to do it, or we give vague answers. And the right thing to do is to give a clear no, because giving a maybe answer is also misleading the other party. And so you want to give a clear no and avoid any vague maybes. Third is if there's a reason needed, you can give a reason, but you don't need to over explain yourself because it's your right to say no. And finally, if you do have an alternative, you can offer an alternative. So maybe you can say something like, thank you for thinking of me, but I can't commit to this right now because I'm currently working on another project, but I know someone that has worked on a similar project before. I can get you in contact with him, for example. These are some other phrases that we can also keep in mind. And one very important statement that I want to address is that let me think about it before I answer. Because sometimes the biggest problem isn't that we can't say no, it's that we just directly say yes. And giving yourself the permission to not answer immediately can prevent a lot of unnecessary commitments. Maybe once you think about it, you can decide that I can help with it partially. And so you can say, I can help with a part of it, but not all of it. So saying no doesn't necessarily mean shutting the door completely. So I've talked a lot about saying no. So if anyone has a situation where you felt like saying no would put you in a difficult situation, or if you have any experience, you are free to share it. And also, if you have any questions, you can share them.
Thank you so much, Dr. Alara, for also beautiful presentation. Thanks.
Thank you so much for the opportunity.
So I think we reached the point for the updates. If there is any updates as far as any projects going on. But in the meantime, I'd like to thank you, Dr. Sabry, and your team. I'd like to thank all the presenters for excellent presentations. So these few days on August 4 and 5th, we had 2 posters presented at the University of Michigan, the pain conference. So I think Dr. Khaled with us and other fellows, if Dr. Khaled available or any of the fellows attending the meeting, please share your experience. I'm gonna share the screen, just give me a second.
Hello, Dr. Khaled. Hello, Dr. Nadia.
Hello, Dr. Malaz, please go ahead.
Thank you so much, Dr. Sabry. Thank you so much, all the presenters, for all the great presentations. Thank you so much, even to Dr. Nadia, for all the opportunities. Dr. Khaled, if you are ready. Actually, Dr. Khaled wants to share his experience with us. I want to actually also thank Dr. Khaled for representing us and presenting our project. I'm sure, actually, I didn't attend, but I'm sure you did such an amazing work and job. Thank you so much. Literally, all of us appreciate your effort. So please, I'm so happy. I'm even so excited to listen to your experience. So go ahead and feel free to share with us all details.
If Dr. Khaled is not available, we can move on to any one of you.
I'm here, sorry. I just
Oh, sorry.
Salam
Go
alaikum.
ahead, Dr. Khaled.
Yeah, I just get back. I was busy something. Salam alaikum. Don't have much about the conference. I can just answer questions, but about the impression about the conference, it was really good to present the conference, and I got some help from Dr. Nader as well. It was really very good experience that I had. There's a lot of questions, of course, some of them related to the project, some of them related came from some people that have experience with research. They ask you what the idea, how you get this idea about making the project. But it was really nice to present. It was really good experience. What I did is practice really not to just read through, but to understand the idea about how to actually selling your idea. I mean, your project. That's what I did. Most of people, they have questions. Someone, when I explain, they go through some questions, and then I explain my idea and all those stuff. And else that I did, pretty much it. Out of that, I mean, the conference itself is really helpful. It's a lot of good and new ideas. There is really good experience for people that presenting they're sharing their project and research, and there is a lot of posters. If you guys see those posters, like, I'm not sure, it's about 40. It's in Dr. Nadir. There's a lot of poster out there. There's a lot of universities that actually share the project as well. And I walked through too. I mean, like to get more experience. Actually, I worked with a lot of. I asked some of those projects. They present some pharmaceutical companies, and they present in a conference as well with their doctors. So it was good experience. Like you said.
Excellent. Thank you so
I'm not
much.
sure if you guys have specific questions.
Thank you, Dr. Khaled. And if there's any
Okay.
other questions for Dr. Khaled or for other presenters, Dr. Noon was presenting the other poster. Also, she had some audience who asked her about the fibromyalgia and if the team is planning to develop a mobile application. And I believe there is a group where they are planning to or in the process of developing mobile application for fibromyalgia. So thank you all. Anyone else wants to share, or if you have questions to Dr. Khalid or for me? I attended the meeting and it was very successful. It was very helpful. There are different topics in the meeting, oral presentations and demonstrations, or showing us some techniques using lights, for example, for addressing some of the conditions with pain. Other interventions were also discussed, so it was very useful, and networking also is an important part. Thank you. Anyone else?
Thank you very much, Dr. Nader, and for my fellow colleagues, and congratulations for the presenters, Dr. Khalid, Dr. Malaz, Dr. Anzal, and Dr. Noon, and all the co-authors as well. I would like to thank all the presenters for today's meeting and also for the attendances, for the attendees for their attendance as well.
Thank you, everyone, and thank you so much, Dr. Sabry. And I'd like to thank all who attended today's meeting. Thank you to those who will watch the recording in the future. And we're gonna finish. If you want to ask questions or if you want to discuss, you can stay for a bit. But thank you all, and have a wonderful day or night. See you next week. Assalamu alaikum.
Alaikum salam.
عليكم السلام. شكرا لك.
Dr. Nader. I'm sorry,
Yes.
just I need a little bit time